Apologies, I don't speak Hungarian. I do apologise, but I've travelled all the way from the UK here to introduce you to a novel technology. We've just been downstairs in the main presentation room where there was a conversation about urethral stricture. And it's great to see urethral stricture and urethral reconstruction thrust into the limelight, because it's an area of urology that is really problematic for many patients, and it's a quality of life issue, and many patients globally are suffering from certain challenges with regards to lower urinary tract symptoms, and stricture is one of those commonly brushed under the carpet disease states that we're here to address. So I'm here to introduce you to, I'm in the way, of the Optilume urethral drug-coated balloon for the treatment of anterior urethral stricture. It's something some of you may have already heard of. There's a lot of social media presence, but also from a clinical perspective, there's a lot of really strong clinical data that is maturing that really identifies its potential and its presence in this space of urology. Next slide, please. Oh, sorry, I've got to click it. Oh, I've got to click it. There we go. So, as I mentioned, urethral stricture is a disease state that has not been innovated for many, many years. It's, we've had standard of care, which is standard dilation. We've had urethrotomy that have been around for many, many years. And then we come to urethroplasty, which is a more invasive operation and a more invasive, more curative option. The problem with all of these options is that urethral stricture is a recurrent disease. And sadly, globally, when you look at the total global landscape, most of the procedures performed globally are endoscopic. That is because they're simple, they're minimally invasive or considered minimally invasive, and they're durable. So it gets patients back up on their feet, it gets patients back to their normal everyday life as quickly as possible without doing too much damage. But sadly, 96% of all procedures for stricture globally is endoscopic treatment, which leaves only 4% as the more curative option, which is urethroplasty. And that can be because of a couple of reasons. A, because it's an invasive operation and not many patients want to have an invasive procedure because it's quite daunting. But also from a training perspective, urethroplasty is very much a fellowship reconstructive urology trained procedure that's quite niche in the area of urology. But ultimately, it is the gold standard considered, but patients still endure and still request endoscopic treatment. Now, depending on which paper you read, historically, the data for urethral stricture is quite prominent, and it ultimately reflects real world. And I hope you agree in the room that the majority of patients do at some stage recur. So, based on data that we know of, roughly 50% of patients fail after first treatment. So once they're presented with initial de novo stricture, they fail. They fail at a certain time point. Now, based on the Haynes-Steenkamp data, that's around 4 years after initial treatment. Once they've had a single failure and they then go on to for retreatment, the success rate is around about 20 to 30%. So again, it reduces again. Once they've had 2 or more failures and they're retreated, the success rate is much quicker and much less frequent. So they typically fail 100% of the time within 6 months. And the issue with historical data sets is only a treatment such as urethroplasty, dilation, or urethrotomy is considered a retreatment, when catheterization it's a form of treatment, so it's a form of re-intervention for the patient. So if a patient catheterizes, that also should be considered a failure, because a patient is having to be re-administered another treatment, a catheter, to actually relieve themselves of their symptoms. So have that in the back of your mind as I go through this presentation. But ultimately, the message here is stricture treatments fail very quickly and very often. So where does that leave Optilume? Optilume is a very innovative technology. As I mentioned, the space of urethral stricture has not been innovated for many, many years. The S-curve dilators was the last real innovation, roughly 15 years ago, so it's been some time. And Optilume fits really nicely into that space. The published evidence for Optilume urethral drug-coated balloon looks at a very difficult subset of patients. These are patients who have failed previous treatments and would typically fail time and time again and be in that stricture cycle. So its mode of action is very simple. It's a mechanical dilator with the application of simultaneous drug delivery. So it's a balloon with a drug coating, to dumb it down a bit, unfortunately. But effectively, it's a guide wire delivered device. So a guide wire crosses the strictured area. The device is administered over the guide wire and across the urethral stricture, and it's inflated. And it's inflated to rupture the urethral strictures, so that scar tissue, and create microfissures in the urothelium. So it creates micro tears in the urethral wall so that the drug can be effectively uptaken and can do its job. So it's a nice and simple demonstration of using mechanical dilation to open up the stricture so the drug can effectively do its job. And the drug's not new. The drug has been used for 25 years in vascular surgery for vascular balloons, for vascular stenosis. And it's, paclitaxel. Paclitaxel it's a chemotherapy agent that we've been known to use, but in very small doses in vascular form, it has been proven to reduce stenosis in vascular. So the founder of those balloons was a gentleman called Li Jiawang, and he sold the patent for that technology to BD, Beth Dickinson Bard, and effectively kept the patent for every remaining technology outside of that area of anatomy. And Eurotronic was his first organisation spin-off, and Optilume was the first spin-off as the product from that. And it takes the same technology. It takes that drug and device combination to open the stricture to prevent restenosis, to prevent an extracellular matrix regrowth, which equates to restenosis. So the drug is very effective, and it's proven to be effective. But what makes it so useful in urethral stricture is, when you think of it mechanically, if you're performing a urethrotomy, you're incising at one single point. A stricture is circumferential, and it's elongated along the length of the stricture. So if you're incising, you're only really pertaining to one area, which is susceptible to reclosing or restenosing again, which is why the recurrence rate is so high. Whereas with balloon dilation, you're opening up the urethral stricture circumferentially, and you're delivering the drug circumferentially along the area of the strictured urethra. So it's a circumferentially delivered drug. It's very precise. Each balloon size has exactly the same dosage of drug per millimeter squared, so it's very precise. It's hydrophobic, so it repels the fluid, urine, whatever it may be, over time, which makes the paclitaxel more effective over that period. But also paclitaxel remains in situ once the balloon has been deflated and removed after 7 minutes, but I'll come on to the procedure very shortly. But it remains in situ during the main stages of wound healing. So I've got small kids, I've got young children, and they're always falling over. They're always cutting themselves, hurting themselves. But it's the same pattern: the granulation, maturation, proliferation. It's the stages of wound healing. And paclitaxel is designed as an antimitotic inhibitor to prevent those stages. And it's designed to prevent the body's generation of an extracellular matrix. So it prevents the body from effectively generating additional tissue or additional layers of tissue. And that's important because paclitaxel has an extended life. So it actually remains present at a non-detectable level for up to 30 days. So although the balloon is removed after 5 minutes, 7 minutes inflation time, the drug remains in situ, working at that level for up to 30 days, preventing the body from regenerating additional tissue matrix. And from a study perspective, again, as I say, there is a maturing level of data set. So we have 3 key studies. Robust 1 and Robust 3 are our main studies. So Robust 1 was our first in-man safety and feasibility study, safety and efficacy, which was in 4 centers in Latin America across 53 patients. Robust 2 is a very small pre-FDA trial. That was a prerequisite before the Robust 3 randomized control trial. So I'll concentrate on the randomized control trial shortly. But so you can see the demographics. Again, Latin America for Robust 1 and the USA for Robust 2 and Robust 3, USA and Canada. For our randomized control trial, standard of care was considered whatever the standard of care was in that specific site. So that was either urethral dilation or urethrotomy or a mixture of both. So we were comparing to what the standard of care typically is right now. Demographics, patient demographics, as I mentioned earlier, historical data sets suggest the more treatments that patients undergo for urethral stricture, the more difficult they become to ultimately cure and rid themselves of stricture. So these studies look at those difficult patient cohorts. These are patients who've had one or more previous treatments. Some in our ROBUST 3 trial, it was actually an average 3. In our ROBUST 2 trial, it was an average of just over 4. But in our ROBUST 1 trial, it was 1.7. So again, difficult patients who would typically fail time and time again. And stricture length is important as well, because typically strictures are quite short and easy to manage endoscopically. These were strictures up to 3 centimeters. And you can see that our averages was around 1.5 centimeters, between 1 and 1.5 centimeters between ROBUST 1 and ROBUST 3. But again, a difficult cohort of patients and within indication from a guideline point of view. And then you look at location. Predominantly, we focused on bulbar urethral strictures. However, there were a small cohort of penile strictures in the anterior urethra that were also treated, and that is an interesting cohort of patients that I will explain very shortly. Prior pelvic radiation as well, very difficult cohort of patients, typically very avascular. They will not really respond to endoscopic treatment, so having an alternative option potentially through Optilume is an interesting potential future study element as well. So defining success, reconstructive urologists would define success, various factors, but objectively, they would look at the anatomical success rate, which is the ability to pass a flexible cystoscope or a 16 French Foley catheter beyond the previous restriction area. And the graph that you see here looks at ROBUST 1, ROBUST 2, ROBUST 3, which is your bars on the left, and also the control arm for the randomized control trial, which was standard of care, so urethrotomy or standard dilation. And as you can see, the consistency in the ROBUST program was around that 74-75% marker, whereas the control arm was mimicking what we see in the real world or what was seen in previously published data for urethral stricture. Patients fail very quickly and very often. And more importantly, I think from a urologist point of view, subjective outcomes, these are patient-specific outcomes. You know, how does the patient feel? Are they happy? Are they happy with their flow rate? Are they happy with their symptom scores? And as you can see, the dotted line, and I apologize, this slide is very busy because it's got all of the studies and the pooled data there, but the dotted line mimics the control arm data. So the control arm of the randomized control trial, which again mirrors real world and previously published evidence for urethral stricture, that patients improve immediately but fail very quickly and very often. And you know, all those patients in the control arm failed out to 18 months in the ROBUST series, and we're actually, interestingly, crossed over with Optilume. And you can see the yellow line on this chart is exactly that. It's that crossover study. So that will be an interesting group to follow out on again. But what you can see here is, based on IPSS and Qmax, there's a sustained improvement in both bother score, so they improve their bother symptoms, their bother scores, but their flow rate is improved and sustained out to 4 years. So the randomized control trial is out to 2 years presently, but our ROBUST 1 data is actually out to 4 years. We've got interim 5-year data as well, but I've not presented that today. But again, it follows that same trend line. It sustains and it maintains out to 2 years in our randomized control trial, and certainly out to 4 years in our ROBUST 1 study as well. So again, both objective, both subjective improvements, so primary and secondary endpoints are improved drastically using Optilume based on the studies. But more importantly, I mentioned earlier that freedom from repeat intervention. So freedom from repeat intervention defined in the ROBUST series was freedom from any treatment, freedom from self-catheterization or catheterization, freedom from any dilation, urethrotomy or urethroplasty. So that's really the true definition of freedom from repeat intervention. And what we see at 2 years in our ROBUST series is a 79% freedom from repeat intervention. And again, if you remember at the very start, the very first few slides, that the historical data set suggests that patients fail very quickly, very often, with typically a 100% failure rate out to 2 years with standard of care. We're seeing effectively 79-80% success rate out to 2 years. So it's really flipping that data set on its head. So patients are seeing a good success with Optilume. And again, this is the final slide. This really breaks down our randomized control trial. So this forest plot looks at the success rate in various subgroups of the study. And what you can see is the forest plot favors Optilume in each of those subgroups. Interestingly, stricture length and also number of prior treatments. But again, you can see bulbar and penile strictures, that there was, with penile strictures, there was a slightly less success rate. The N was very small. But again, it begs the question, for penile strictures that are very difficult and challenging to treat endoscopically, is there an alternative option? Is there an alternative minimally invasive option that can be defined with these patients specifically for penile stricture? The indications for Optilume are very simple. It's anterior urethral stricture treatments, less than 3 centimeters. So it's a very specific patient set, a very defined patient set, but it's pretty much the majority of the stricture market. The majority of strictures are generally short, less than 1.5 centimeters, and Optilume's indications for use is within that range. And again, from an economic piece, we're very fortunate that in the UK, NICE has assessed the technology through its very in-depth program, both clinically and economically. And what they defined was, based on all of the clinical evidence for stricture and Optilume, they defined that using Optilume represents a potential cost saving of £2,502 per patient over 5 years, which is a lot. There are 17,000 stricture treatments in the NHS alone every year. So that's quite a drastic saving on an annual basis for the NHS. Now, naturally, that needs to be extrapolated for other markets around Europe and the US. However, what that is really based on is freedom from repeat intervention and freedom from resource utilization in a healthcare scenario. So follow-up clinics, follow-up visits, catheterization, etc., etc. So that whole cost saving is built on a spectrum of care. And I think more importantly, when we look at, given that that Optilume has been commercial since 2021, which is quite a short time, we've already developed NICE guidelines in the UK, and most recently this year, EAU and the AUA published guidelines on Optilume very specifically and included them within their guidelines for the treatment of anterior urethral stricture. So from a data perspective, the data is maturing very well. The patients are in the real world are also mirroring that data, which is, it shows sustainability and consistency. And the technology, it's a very simple procedure that requires a very little learning curve. But again, a minimally invasive treatment as an alternative option for the armamentarium of urethral stricture in a urologist practice. But thank you very much for your time, and if anyone has any questions, please feel free to ask. Oh, sorry.
Thank you. It was a very interesting lecture, and and only one question, because if you comparing the three different studies, the robust 1, 2, 3, it is difference at the background of the patient. The robust 1 is mainly for iatrogene, and robust 2 and 3 maybe the idiopathic etiology background. But you comparing the effect, how do you think? Because in the guideline it say that minimum after 2 procedures than before. Is there any influences the effectivity of the balloon dilatation depending of how many procedure was before, what kind of procedure, and what is the scare of the stricture? Because we know that the scare, that's the problem that provides the patient the uretroplastic, because it is not only the stricture background, it's everywhere in the scare.
Yes.
And how does it prevent the scare rebuilding after the balloon dilatation, this drug?
No, good question, and it's what really hinges upon and touching on the procedure. So ideally, in all studies, a pre-dilation was formed, so a standard S-curve dilation or a urethrotomy prior. What that does is it gives a little bit more give in the scar tissue. So if you do have a dense scar, so there's two methodologies. If the stricture is relatively open and you're able to pass a guide wire quite freely, there's no real requirement to pre-dilate. However, if you have a white fibrous ring around the stricture, it's going to be pretty dense. So you may want to predilate, or if it's very constrictive or obliterative, you may want to predilate. That predilation just opens up enough, creates some microfissures initially, for then the balloon, and the balloon is 30 French, which is quite large. So typically you dilate to 20 French with a standard dilator. This is a 30 French balloon, so it's creating even more distension of the urethra to get deeper into the urothelium, so the actual drug can do its job. As I mentioned before, that the drug is a proven antimitotic, and it's designed to prevent an extracellular matrix growth, so additional scar tissue reformation. And the demographics of the patients are relatively similar. The number of treatments were 3.2 in Robust 3, 1.7 in Robust 1, but typically these patients would fail time and time again, as we've seen in historical data sets. But from a perspective of results, we're seeing a very consistent result between 1 treatment and 5 treatments, and as the slide suggests here. So you can see the number of prior treatments. There was very little in the way of, and it's the bottom 2 points, there was very little by the way of number of prior treatments. So patients with less than 5 treatments and patients with over 5 treatments were determined. And the number was small, but as you can see, it was far superior to the control arm, and there was very little difference between those groups.
Thank you. And only the last question is, do you have any examination about because you show that the bulbar and bulbosa stricture you mentioned. What about do you examine this balloon effectivity after the bladder neck stricture, the radical prostatectomy, because also the main problem, because that scut you very quickly can get this repeatedly cutting the bladder neck. You will get for instance the osteomyelitis of the bone.
Yeah.
What is the? Do you have any experience about it?
It's a great question. It's one we often get asked. It's yes, we don't have any published evidence. I think I need to start with that. We don't have published evidence for bladder neck contracture. However, in the real world, physicians have utilised Optilume for bladder neck contracture. I can't stand here and talk about published efficacy because I don't have that data, but anecdotally, what we hear from those physicians is the results, the early results, are very positive. The technique that they use is slightly different. They make short, shallow incisions around the clock of the bladder neck, very shallow incisions, and then place the balloon and open the balloon to 30 French. So anecdotally, the results are good, but until a single centre or a multi-centre publish their evidence, what I would say is that is purely physician experience rather than published evidence right now. But the technology has been utilised for bladder neck contraction.
And finally, last question: what about the price in Hungary? How we can?
That's a question for.
In our ureterotomy procedure, not so paid.
Yeah.
Then
It's still a relatively new technology globally. The reimbursement is a challenge everywhere we go. What is really interesting is, because urethral stricture is kind of brushed under the carpet, these patients wait 1 year. The waiting list in the UK is 3 years for a stricture treatment. So these patients are determined to self-fund or fund in a way their procedures. And no matter which geography we work in, whether it's Spain, Italy, Greece, Poland, or wherever it may be, we find that the clinical need and the clinical the value of the product clinically and economically outweighs the initial cost. So we're seeing a huge interest and ultimately patients who are very determined to have an alternative treatment, and it fits within that middle space of standard endoscopic treatments. That's where it's they would always be treated with a standard endoscopic treatment first. If that was to fail, then what would be their pathway? And now you have Optilume in that middle pathway. And if Optilume was to fail, which 20% of patients do based on the data, then urethroplasty is the final option. So it's kind of that middle ground now. It's that alternative option for those patients. But you're right, reimbursement is a challenge everywhere we go. But what we do see is that the clinical need is outweighing and the value is outweighing the initial cost.
Thank you.
Thank you, everybody.
Thank you for